Hi, welcome. My name is Dr. Dean, and I'm here with
Venzel.
And so, in this video, we want to discuss how to appraise or assess or examine spinal stability. Okay, so the first thing we need to try to understand is who is the patient. Is the patient an athlete? Does the patient have an occupational injury? Does the patient have
A developmental injury as well.
Yeah. Does the patient have knee pain and contributing to undiagnosed spinal instability, right? So the question is, they're not necessarily coming to you with back pain per se, right? So what do? So the patient's in front of you. Let's say you're the patient. I say, "Hey, Venzel, thanks for coming into the office today. What can I help you with?"
I'm suffering from just a pain. It rotates from my hip, my knee, my ankle. Then I feel it in my mid back sometimes. And I just want to find out what's going on and what am I doing. And yeah.
Okay, so just to keep this really brief, I would ask him LOPPP, QRST, psychological components, review of systems, right? All this drugs, I should say drugs, medications, right? And then any personal biases for or against treatment or fears about treatment, right? And then I want to know, especially about the psychological component, how is this problem interfering with your sports activities, your activities of daily living, right? So we would go through all of that. He wouldn't just say, I have sort of this rotating thing. You did say you were suffering. I'm sorry. Right? It's kind of moving around, so it's a moving target, right? So that's where the clinician starts to panic. Oh my God, what am I going to do? Okay, so kind of anything that presents, especially with athletics, automatically assess spinal stability, right? So if you're wondering, like, where do I start? Like, most of his complaint was lower extremity, but it was pretty much the full scope of the horseshoe, right?
Yep.
So we talk about the horseshoe, it's from the foot, we talk about all of the function of the foot, including the plantar fascia, right? Up the back of the ankle, across the top of the foot, up the 360 of the lower limb, the upper limb, across the pelvis, down the other side, and then of course the base of the spine, or you can include all of the spine, right? All the way through the ilia and into the transversus, right? Psoas, all of that. Now you can't really say, that's the end of the assessment because, these two complexes are the roof and the floor of the spine. So then, that's when the clinician really panics because they're like, oh my God, I only have, 3 minutes to do a full exam. How am I going to do that? Well, we could almost say that if you just take it back to the foundation of the problem, unless, like, I just kind of smashed my finger in our whiteboard. So my finger, I could say, doctor, my finger hurts, right? But that's different than spinal stability. So we're talking about mostly athletic complaints, right? Or occupational complaints, or you can even say ADL complaints, right? When I play with my grandkids, it's all over the place. Or I could just say lower back, right? So if we're looking at stability, a good assessment isn't going to elicit pain. It may, but it's going to elicit the wrong response. Right? So if I have you put your feet together and stand with your arms next to your sides, right? So now your base at the bottom of the base is smaller than the top, right? So he's smaller at the bottom and wider at the top, okay? So now if I just take my hand and tip him, right? He should somehow respond, right? Put your feet back together. He should try to somehow respond to that force, right? So he may lean on the other side, or he may activate into it. So try to activate into here. Turn so they can see.
Okay.
Right. So put your feet back together. So base is smaller than the top. So I'm going to give you a lateral force here, and you can activate into that, right? So what I'm noticing, yeah, go ahead, push. Right, but don't push with your hip. Push from the point. That's not easy, is it? Right? But it's letting me see, is he able to maintain this, right, with a very narrow base? So this is the most difficult of them, right? And then I'm going to try to rotate you on this very narrow base. And we're going to looking for his counter rotation capacity, right? And then we're going to accelerate. So I'm going to accelerate into you. Remember we talked about that quickness. I'm going to accelerate into you. Just contact here. Give you a little push. Give you a little push. Give you a little push, right? And I'm looking to see if he's just going to automatically crash to the side. Okay? So that's lateral bending and rotation. Right? And then we're going to do a shear to the spine. So I'm going to go into his hip here, and I'm just going to push quickly, push, and push. And so I should get a little bit of a response. Push. Right? Okay, that's good. All right, now give me a wider base. Same thing. And turn towards me a little.
Okay.
Yeah, and then, so I want you to bend your knees, bend your hips, tip your chest forward, and then put your arms out forward, open up your fingers. Yeah, so this is like the classic core neutral position, right? So now I'm going to see what his response is like. So if I rotate here and he forcibly rotates, show him what it looks like, forcibly rotates the hips to the other side, your hips, like that.
Okay, you want to?
Yeah, right? So that's not spinal stability. So do it again. So I'm rotating him this way, and right? So that's not spinal stability. So spinal stability takes this force across the core. So I'm rotating the upper while the lower stays still, right? So try it again. So spinal stability looks more like this. So this is just rhythmic stabilization. And I would tell him to try to keep his pelvis as still as possible. Go ahead and show them that same thing from the back. Yeah, just turn towards this way a little bit.
Sure.
Yeah. Okay, so come into that core neutral position again. Good. So watch his hips here, and as I rotate him, and I ask him to keep his pelvis still, right? And he can do that pretty well. Now go ahead and turn around, face forward. So we're looking for the rotation of the pelvis. The other thing we're looking for is that valgus knee, right? So when I try to twist him or force him, the knee starts to pull down and in, right? That's not spinal stability. So let's show them what that looks like. Just face me a little more. Yeah, and then come into neutral. Good. So if I rotate him and he anti-rotates, right, it could be either knee. It could be this knee or come back to neutral, and it might be this knee, right? So that's not spinal stability because his ground force reaction should not be coming through a pronated foot. Right, so that's another way to assess spinal stability, okay? Now, I like this is a little controversial, okay? So I'm going to get the Swiss ball. Okay. And what I want you to do is put the Swiss ball on your chest. I want you to give it a big bear hug. Okay, and yep, just like that. Yep, you can interlock your fingers. Okay, bend your knees a little bit. Just find a comfortable standing position. Okay, so don't let go with your fingers. Okay, so it's important that they. Now we're gonna do some really intense acceleration. Okay. Now you could ask, does this elicit any discomfort or pain? So when you get into this, they may get a little spasm. They may get a spasm in their QL or in their transversus or their mid back, upper back. Okay. So we're gonna start with rotation. So we talked about. Remember we taught that cornstarch thing. We talked about that quickness, right? So spinal stability means, so don't assess for back strength. You're not going to do back extensions. We're not looking for muscular strength. Spinal stability is the connective tissue, right? It's the tendons, ligaments, those strong sheets. They're like fiberglass sheets of the thoracolumbar fascia, okay? So, and now, so hold on tight, right? And this is like a 45 centimeter ball, and you can even underinflate these and they're a little bit better. Okay, so we're gonna go into rotation. So I'm gonna have you close your eyes. Good, and so you're just gonna feel. This is a little test, right? Just gonna feel. Just feel. Feel. Good, now I'm looking for him to return back to the center as quickly as possible. That's accelerated rotation. Okay, how'd that feel?
I felt it. So I felt the ball trying to spin, like it wanted to spin, the Swiss ball trying to spin out of my hands. One, I had to get, and first I had to engage my pec.
Yeah.
I'm hugging.
To hold on.
Yeah, so once I engaged my pec, once I got into that comfortable, like my power stance, so core neutral, for me, I was able to kind of deal with any force that I wasn't anticipating it, but I responded to it as soon as I felt it. So I was very, it wasn't just reactive. It felt more proactive. So as soon as I felt it, I was able to elicit a response back without even having to do too much thinking.
Right.
Yeah.
So that's great. And so what we're looking for is, of course, your verbal feedback. Right. Make sure that you don't just do straight leg raise, right? And does this hurt? And then get your goniometer and measure 70 degrees and then open up your book and see what that says.
Yeah.
Right? So what I'm looking for is, this is non-traditional, right? So I'm looking for what I'm looking for. I'm looking for you to be able to respond. There's no orthopedic exam for that.
Yeah.
Right? So everything that's about this stuff, gains, lens, and circumduction and all that stuff, right? That's all laying on a table and there's no ground force reaction. So remember, in order to assess this, we need to go back to the definition of spinal stability. So we have to have axial loading, absolutely have to. We're multiple planes, so we just did rotation, lateral bending a little bit already. We have to have acceleration into deceleration, have to, right? You can do that a little bit with the rhythmic stabilization. And this has to be meaningful, right? So don't do a drill, don't assess something that's not meaningful. Straight leg raise is not meaningful. Nobody does this, nobody. So even laying down, nobody does that. I mean, you might do it in yoga class, right? And then aerobic and anaerobic. So, we would bisect this particular drill, and we might take it to 15 seconds for anaerobic, and we might take it to a minute or 2 minutes for aerobic, and then start to look at the muscles breaking down because you're getting tired, which is my complaint with classical orthopedic exams, is your patient is basically being a corpse, or as close to a corpse as possible at a super low metabolic rate.
Exactly.
Right? And then you're doing one drill to them once while they're cold.
And it's multiple muscle fiber types too that connect. You have type 2X, type 2A, type 1. So training anaerobic and anaerobic is, anaerobic is training that energy system as well. So
exactly. And within the definition of spinal stability.
Exactly.
Okay, so let's come back into that same bear hug. And so now I'm going to do flexion and extension. Okay. So just come into a comfortable standing position. Okay, so you're just going to feel here. Okay. So this is more leaning towards aerobic. So we're just looking for how, over time, he starts to modify, right? So he's doing a little bit of expectation. If I don't hit, he goes down. So we're looking for, that's better. Good, so we might do that for 2 minutes. So that's an example of his reaction is to flex and to reset, flexion and extension. Okay, so how did that feel?
I felt it too. I felt exactly when you were explaining what you were. My body got used to it, so I started to expect like when you were going to hit, because I'm very good at catching patterns.
Right.
But as soon as you change it up, I have to be aware. So like we talk about.
Don't respond unless there's a force.
Exactly.
Right.
So I had to hold that, and as soon as I felt it, I was able to go back to that shape. So I was able to go back to my neutral state again, because I wasn't anticipating, wasn't drawn down. I received that force and I responded immediately, and I went back to neutral versus here to here, back to here. I didn't have to find, I didn't have to search.
So then you could do the same sort of assessment and get sort of a unilateral response by doing it like more in a lunge position. right? And so you could check more one side versus the other, sort of the response, right? And then again, after the assessment, for sure, make sure you ask the patient what kind of experience or what kind of feedback they have, and make sure they have ample time to describe. Okay, so these are a couple of examples of how I would assess spinal stability. And you notice, it's super accessible. It's just a 45 centimeter Swiss ball, and and the patient, and then it's just a little bit of space. But you notice I didn't have you lay down.
Nope.
Right? And you're not doing any single joint exercises, right? And in isolation, we're checking whole systems and guarantee there's acceleration and deceleration.
Yeah.
Right? So if you weren't as trained and we did those drills, you may actually end up letting go of the ball or saying, I can't take it anymore, right? Or it may activate something that goes into a spasm, right? So I just wanted to take this opportunity to let the folks know that this, is an unconventional approach, but that it works, really great. And the main feature of it isn't the dogma of research and what works and what doesn't work. They talk about that, sensitivity, and that's all great. But what matters more is what you experience and what you say, right? And this can be modified. You can do this, a bunch of different. You could do it even in rotation, right? Okay, so I hope you like that. It's always fun for us to explore. So, Dr. Dean.
Venzel.
And thank you for joining us again.
See you guys soon.
Just stay with us. We got more.